Well, thank you, everyone. I'm just going to jump in. My name is Mary Petrie, and I'm the parent of a young adult with misophonia and a frequent volunteer with soQuiet. Thank you for being here, and it is my pleasure to introduce Jane Gregory, who's the author of the first conventionally published book on misophonia, Sounds Like Misophonia. Dr. Gregory is a clinical psychologist who both has misophonia and researches the condition at Oxford, where she also runs the NHS Service for Misophonia, and that's a publicly funded national therapy service. Dr. Gregory has made significant contributions to misophonia research, including co-creating the SFive, an assessment or diagnostic tool. Today, Dr. Gregory is going to discuss her 2023 paper, Session-by-Session Change in Misophonia, a descriptive case study using intensive CBT. We will start with an overview of this work by Dr. Gregory and then ask questions. So, Dr. Gregory, I'll turn it to you.
Lovely. Thank you very much for having me, and thanks soQuiet for inviting me and for putting on this absolutely amazing free event for people. I often say that I could literally talk about misophonia for days, and I'm delighted when people invite me to do it to masses of people. So thank you for having me. I am going to be talking about this case study. There were two papers that were published around the same time. One was an individual case study and one was a case series, which is a sort of consecutive number of patients who came to see us for misophonia. So I'm going to be talking about both of those today, but I'm going to be talking about it in the context of what we have learned about misophonia through doing therapy. And some of this will be stuff that you already know because you're the ones going through it, but I learned a lot through working with patients. And I think it's a really important part of therapy is reflecting on what we learn from therapy and using what we learn from therapy to guide our research. So I'm just going to switch now to my slides, I hope, very slickly. Switch over. Okay. So learning through doing, that's a really important part of therapy and research for me, is that the things that we personally go through ourselves or that we go through with another person are the things that we learn the fastest from. And so this is about my learning from working with people with misophonia. So this is me. My first trigger was pigeons outside my window when I was about 8 years old. I was convinced that they were deliberately trying to stop me from sleeping, relaxing, reading. And very quickly, food, chewing gum, clocks, and then more recently, mobile phones became a problem for me. My two top strategies for dealing with misophonia are my trusty headphones and my death stare. And this is one that I mastered at university, just sort of glaring over my shoulder at people who dared to bring food into lecture theatres, which I still think should be a crime. Okay, I just want to quickly acknowledge the people who I worked with on these two projects. Celia is my co-author of the SFive that Mary mentioned. We have worked together for 5 years now and very much partners in crime. And Paul and Victoria, my research supervisors, and Tom and Chloe, who are therapists who worked with these patients as well. So I'm what's called a clinical academic. So I work both as a researcher and in clinical practice as a psychologist. So the goal of the work that I do is to start with observations that we make in therapy, use that to come up with theories about why something works the way that it works, and then use that to develop questions that we can test doing research, and then use the results of the research to take it back immediately into therapy so that we can very quickly use the outcome of research to help the patients that we're working with. So here are some lessons that I learned from the very early days of my work in misophonia. So this was the first 19 patients that came through our clinic for misophonia. So lesson number 1, misophonia has layers. I'm going to go into these in more detail. Number 2, change is possible. Number 3, you are the expert, and that's you, the person with misophonia, not you, the therapist. Number 4, traditional exposure is not the answer. And number 5, coping strategies are complicated. You'll see what I mean by that later. So let's just start with misophonia has layers. I think in the middle of misophonia is a meerkat. Now, meerkats, there are, within a group of meerkats, there are these super guards of meerkats whose job it is to spend most of the time on top of the hill, watching out for potential signs of danger. So if there's immediate danger, all the meerkats run back into the burrow. But this meerkat's job is to not ignore possible signs of danger. So if they see a rustle in the grass that could be a snake, or a fluttering in the sky that could be a bird of prey, this meerkat will be on guard, watching. And I think that that's a bit like misophonia, that we're on guard. Our ears just don't switch off. They treat all of these sounds as if they're potential signs of danger. The problem is we then get these intense reactions. We get angry. We blame other people for the noises they make. We blame ourselves for the noises we make, for our reactions to those noises. We have fears about what we might do in response to these noises. We have worries long-term about how misophonia might affect us. We think about it over and over and over again, even when there are no sounds present. We have coping strategies like listening to music and blocking out sounds, but also coping strategies like hiding our emotions, or maybe listening out for sounds, trying to check if there's any sign of danger. Maybe even being self-conscious about your own sounds. And then we've got the impact of how people supported us during childhood or didn't support us during childhood when we were reacting to these sounds. And then the level of support that we have now, and of course cultural factors, which will also influence someone's experience of misophonia. So you can see that we've got the meerkat in the middle, but then there's all these layers around it, and some of those will and some won't apply to you, but there are lots of possible layers. One of the good things about lots of layers is that that means there's lots of areas that we can potentially change. So I'm going to talk now about the first 19 patients we saw for misophonia in our clinic. There was a 20th, and that person left therapy for completely practical reasons unrelated to the treatment, so we haven't included them in this analysis. So this is just looking just quickly at how it went for them. So this was 19 patients, 17 were female. As we're learning, women tend to be more likely to volunteer for things for research and to seek treatment for misophonia. They were mostly white British, age range of 17.5 to 51, so a wide range of ages. And there was an average of 13 hours of cognitive behaviour therapy. And some people had a lot less than that, some people had a lot more than that. That's just the average. So they range from 8 to 19 hours. Now, if we just have a look, when we started, we used the two measures of misophonia that were available at the time, which was the AMIS-OS and the MQ. And as you can see, the pink is when they first came to see us, and the sort of greeny blue colour is when they came for a follow-up, or we contacted them for a follow-up. And you can see that there was a 40% reduction in change in the AMIS-OS and 38% in the MQ. So a good amount of change. But what we found was that people were saying they were changing more than was represented in these questionnaires. And that's where the SFive, the scale that Mary talked about, came from. So I contacted Celia, who was working on this scale, and using some of the observations and feedback from people in therapy, we worked together to create a scale. And I just want to show you what happened with the 7 patients who, by the time this scale was ready to go, the 7 patients who did the SFive as well, just so you can see the difference in how it measures. So there's 5 aspects of the SFive. There's feeling like the other person is doing something wrong, and there was a 57% change in that. Feeling like you are the one who's wrong for reacting the way that you do, there was a 68% change in that. Feeling overwhelmed if you're unable to get away from sounds, 51%, so a bit less change in that. Fearing that you'll act out or being verbally aggressive or shouting, a 68% change in that, and a 57% change in the impact, sort of how limited you were by misophonia. So you can see that this questionnaire captured more change than those other 2 questionnaires. And I just want to show you, this is one individual patient. So this is the one in the published case study, Isabel, who had 12 hours of therapy, but over 5 sessions. So there was, some of the sessions were 3 or 4 hours long. And you can see that there's, I hope I can show you here, there's just a much sharper drop here. And this is really helpful for therapists and researchers to learn more about a condition, because it shows that there was something that we did after session 2 that led to a sharper decrease in symptoms after that. And that was actually the first time that Isabel herself volunteered, because she wanted to play around with sounds in the session and see whether she could make some changes. So that was her idea to do that, and I'm going to talk a bit more about that in a moment. So that's that point just there. So lesson number 3, you are the expert. I had misophonia. I thought I knew a lot about it. I'd read as much as I possibly could, but every single person that I saw, every person who the other clinicians that I was supervising saw, we learned something new, and very quickly learned that the experience is so individual that the person with misophonia is always going to be the expert. So the therapist's job is to firstly drop all of their assumptions about what they think it might be, because all the instincts that we have from other disorders could be wrong with misophonia. And if we go into it expecting them to be right, then we end up invalidating the experience of the patient. So our job is to listen and believe the patient's experience, to provide some context, to sort of think about the idea of the inner meerkat and think about the role of childhood experiences maybe, and help to understand patterns, but we're there to give the context, not to explain their experience. We're there to give options of things that the person could try, help them design experiments to test things out, to find out more, to stop when the patient asks us to stop, and to change direction when the patient asks us to change direction. The patient knows whether something is likely to be helpful or not, and definitely knows when it's not going to be helpful. And then our final job is to help reflect on the results and use that to decide what to do next in therapy. Number 4, traditional exposure is not the answer. So traditional exposure is when what used to be used a lot in phobias and anxiety disorders. So the idea is that you sit with the thing that makes you anxious and you just wait until the anxiety comes down. It's a way of sort of showing your body that this thing isn't dangerous. The problem with that is it's extremely unpleasant to do, and also that the results don't generalize very well over to other situations. The other problem is that it doesn't work very well with anger. Instead, what happens, instead of the anger coming down as you stay with it, anger often goes up. So it's the opposite of habituation. It also doesn't work very well with disgust or with shame. And those are 2 very common experiences in misophonia as well. I'm just going to explain what we do instead, because we do think that involving sounds in some way may be an important part of therapy, but certainly not straight away, and definitely not using that traditional exposure model. So I'm just going to explain about associative learning. So this is the idea that our brain very quickly pairs sensory information with meaning based on our experiences, based on our worldview, based on our interpretation of events. So let's just imagine this is me at the age of 9. That's my twin brother, Chris. And his eating makes me just a little bit uncomfortable. Not big, strong reactions yet, but it does make me a little uncomfortable. Let's imagine then that I have a really tough day at school. All I need is some quiet. I've been overstimulated. I need to rest and everything to be quiet. And I get home, sit down at the dinner table, and I hear my brother eating. And that makes me angry because it's the opposite of what I needed in that moment. So now the sound of my brother eating is associated in my brain with anger, not just with like, oh, that's not very nice. Now let's imagine I feel angry when I hear this sound, and my mum tells me off for reacting that way, for snapping at my brother, for pulling his food away from him. And I get upset because I've just been told off for something that I really don't think is my fault. So now the sound of my brother eating is associated not just with being angry, but also with being upset. And this can be specific, just my brother's sound. And if I hear a panda adorably eating something, I don't get the same reaction. But it could also generalize. So it could be that then any eating sound causes the same reaction. So that's just different brains work in different ways, and different sounds work in different ways. So the way that we work with that to help us change misophonia is to create new associations with the sound. And this is called inhibitory learning. And this is basically to inhibit the old learning and create new learning. So let's imagine my brother's eating makes me angry and upset. And then what we do is we take the sound of my brother eating, but we pair it with a video of a panda eating bamboo. Same audio sound, but I'm watching a panda instead of watching my brother. And then I think, oh, that's interesting. My brain wasn't expecting that. I thought it was going to be a person. It was a panda instead. So then it breaks the association. This doesn't happen quite as quickly as I'm explaining it, but I'm just giving a really simple example. So instead of feeling upset and angry when I hear that sound, I'm back to feeling like, oh, I don't like it. It might be annoying, but it doesn't give me that fight or flight kind of reaction anymore. The other way that we can work on it is what we call memory rescripting, which is where we go back to these childhood memories and actually update them. And this is a really normal process that our brains do automatically, but some memories get frozen in time. So we could take this example of mum telling me off when I was getting angry at my brother's eating sounds and think about, well, what did I actually need in that moment? I definitely didn't need to be told off. What I needed was maybe someone to explain what was going on, and maybe I needed a hug. So we might imagine that memory and add in what I actually needed at the time, so that that little kid within me who is being triggered off when I hear these sounds of eating then feels a little bit more supported and comforted instead of told off and shamed. So that's another way of changing our associations with sounds, and that's another one of the things that we did in these sessions. And so then again, I might go back to being annoyed by these sounds, but I don't get that sort of really childlike anger and rage that I got when I was a kid. Okay, and number 5, coping strategies are complicated. So with some other disorders, we know that behavior plays a huge role in keeping the problem going. So for example, with social anxiety, if you are really self-conscious and hide your mouth because you're really worried about appearing nervous, you don't want them to see your lips looking wobbling or something, but instead of that making you look more confident, it actually makes you look more nervous because now you're covering your face, and it can make you feel more like you appear nervous because you're acting as if you appear nervous. So in some disorders, we know that behavior plays a part, but we don't know that for misophonia. And what we discovered through this case series was that it's different for each individual person and each individual coping strategy and each individual context. So somebody could use earplugs to help them fall asleep, and that is really helpful. It helps them to sleep. They function much better with earplugs. Someone else could use earplugs, and what that does is it fuels the belief that they will never sleep if they don't have earplugs, that they can't handle being awake, that they can't handle not having enough sleep. So for some people, the exact same behavior could make them feel worse over time, and for others, it could make them feel a lot better. And so that's the direction that my research is going in now. And I just wanted to talk just very quickly about the types of coping strategies, because I think it's much broader than we expect. So we've got things that you do to sort of escape or block out the sound. We've got things that you do to signal to the other person that you know what they're doing. It's like glaring at them, maybe offering them a tissue, like you're trying to be helpful, but actually what you want them to do is just blow their nose and stop sniffling. Things that we do to hide our emotions or to calm our emotions. And things that we do in between sounds. So that involves planning how we're going to deal with sounds. It also involves thinking a lot and ruminating over events related to sounds. And all of these things can have either a positive or a negative impact, depending on the situation, depending on the context for you as an individual. And so what we do is we distinguish them in therapy with the person. Does this help you to participate in life? That's helpful. Does it help you to achieve your goals? That's helpful. Does it help you cope with distress rather than avoid distress altogether? Because if you're avoiding distress altogether, what you do is you teach yourself over time that you can't handle distress. It's okay to want to be able to cope with it better or to not have to experience it. But if you avoid it all the time, that can be an unintended consequence. Helpful coping strategies elicit support from other people, but they also respect other people's needs and rights, and especially where there are families that have competing needs. So maybe someone who needs to fidget to release their anxiety and someone with misophonia or misokinesia who can't stand the sight of fidgeting. So we have to work out together in a group how to manage these competing needs, and helpful strategies are ones that also respect others' needs. And the way that we tested that in the sessions was we work out what's the point of the strategy. Is it working the way that it's intended to? Are there any unintended consequences? And then we compare it with alternative strategies, and we may go back to the one you're already using. That's completely fine. We just want to make sure that it's actually the best strategy for you. Weigh up the pros and cons and then adapt as needed, which means that you might use one strategy in one situation and a completely different strategy in another situation. So what we hope with this therapy over time is that we start to remove those layers that cause misophonia to feel so much worse. And instead of having that intense anger reaction, we might be annoyed by these sounds. We're still distracted by the sounds. That inner meerkat is still very alert and paying attention, but we don't have all of those layers that make it so much worse. And that's the end. I will stop sharing my screen.
Thank you so much, Dr. Gregory. And I will go directly to the chat where you actually have some death stare solidarity. So people are in agreement.
Excellent. Feel
But
free to send me photos of your death stares on social media. I love to see how people do it.
That could start a whole social media wave, the death stare. Let's start with something that might be broadly helpful to many people. How do people in the UK access the NHS services for misophonia? What's the pathway for that?
So that's a great question. So for some people, they'll be able to access local services. So that could be primary care psychology services. It's now called talk therapies, or local audiology services. So that's sort of the first point of call, is to see what's available locally. Some services will have people who have heard of misophonia. Some of them will have come and done our training at Oxford. And so we're trying more and more to spread good teaching about how people can be respectful and work with people with misophonia. If it's not available locally, then the Oxford Clinic does accept referrals from anywhere in the country. It's England. We also take referrals from Scotland and Wales, but it depends, and Northern Ireland, but it depends on funding from your local area. So once the referral's been accepted by us, then your referrer has to apply for funding to come and have treatment with us. So we would prefer over time for more therapists and audiologists to get trained up locally so that people can be seen nearby. But for now, that's an option, is to for us to see you in Oxford and to apply for funding from your local area.
Thank you. That is super helpful. Thank you. Someone else would like you to talk a little bit more about the cell phone as a trigger. And a couple of people liked that. So I think there's some interest in the cell phone as a trigger.
Yeah, I am fascinated by the cell phone. I absolutely hate it. And for me, it's the worst is when I'm on the quiet carriage on the train and someone is there on speakerphone. I wonder if I can, I'm just going to show you something, because this is how much I hate cell phones. I had these badges made.
Oh, that says good morning to everyone except those on speakerphone. That's awesome.
So one of the reasons cell phones are so annoying is that our brain is, especially if there's speaking or video, our brain is always trying to comprehend language. And so if it hears something that sounds like it could be talking, your brain is trying to work it out, which takes you out of whatever it is that you're doing. If that sound is distorted, which it always will be if it's coming from a speakerphone, because the sound is directed at the person listening to it and it's not intended to be heard outside of the person listening to it. So it'll be distorted. So your brain has to work even harder to try and work it out. So there's already that. There's the distortion. There's the fact that your brain is working hard to try and figure it out, which is tiring. There's the fact that it's unpredictable, especially if it's jumping from video to video, and the fact that it's completely out of your control. Sounds are much easier to deal with if they're predictable. You know when they're going to end. And if you have any kind of control over it. But if it's somebody else, and there's also that sort of weighing up of, should I go and tell the person off or not? Will I put myself in harm's way if I go and talk to them? So then you've got the added layer, so we're talking again about layers, you've got the added layer of debating with yourself about whether you're going to do anything about it, which creates more uncertainty and more of a feeling of not being in control.
Thank you. Thank you. I'm going to combine a couple of questions about families, and people are wondering, how you help small children and families and what you might do when a parent's voice is a trigger. Could you just speak generally to the problems that families face?
Yeah, and it is really tough. I'll start by saying that. And the fact that you're here and trying to learn more, you're already doing more than most parents, so well done. Listening and believing your children is really the first step. I want to say something about voices, because I think there's something really, really interesting about voices, is that there's been some research that was not to do with misophonia, but they found that as teenagers go into adolescence, they start to find the sound of their parents' voice grating, and they start to prefer the sound of their peers' voices. And it's a really, really normal part of development because it helps us to become independent, to form connections outside of our family unit, so that we've got, we can sort of create a life outside of our family. So it's a really, really normal part of development. But if that is happening alongside misophonia, then that grating noise of your parent's voice can then be compounded because of the misophonia. So a really normal developmental thing then becomes something that really disconnects you immediately from your parent in that moment, rather than gradually over time. It's only meant to disconnect you a little bit so that you'll make other friends. It's not meant to make you hate your parent in that moment, but that's what it can feel like for the kid that's experiencing it. So I just want to reassure that it's a really normal developmental thing to find your parent's voice aversive, but I have all the sympathy in the world because it's a horrible thing to go through when you have misophonia. And then the other thing, just in terms of what you can do with kids, what we're learning is like the listening and validation is really important. And there's sort of a group of needs that kids have, and validation is one of them, but also setting boundaries. So it's also about sort of helping kids to understand that while this is distressing for them, we also have to think about other people's needs in the family. So sort of that part that I was talking about at the end about respect needs, it's teaching kids early on that sometimes it will be hard and we won't be able to do anything about it because we need to get on with our day, or we all still need to eat dinner, or your sibling needs to do this tick or whatever it is. So that's also one of our emotional needs, is to have really clear and consistent boundaries. So that's part of the process as well. Sorry, I'll move on to other questions, but I could talk all day about it. I'm sorry.
That's a big one, and I tossed you a 3-hour-long question. But another question is, what if people have no memory of that first trigger? How can inhibitory learning work then if there's nothing to pair it with? How do you work to create new memories?
Yeah. And we're at about 2 minutes, by the way.
Thanks, Chris. So I'll just, there's two different parts there. So the inhibitory learning can be done just in the present moment. You don't need to know what the old connections are for that to work. You can just create new experiences with the sound. So that just means it might be just doing sort of silly or funny things involving the sounds, or just interacting with them in a different way. And that process can still work even if you have no idea where the original memory was. But also for the childhood memory stuff, what we do is we bring a recent example of being really upset and distressed with misophonia to the surface, and we get people to close their eyes and just float their memory back to the first time they remember feeling that way. And almost every single person that we've worked with, they've gone back to a relevant memory. Sometimes it's really clearly sounds related, and sometimes it's just emotionally related, and we still work on that memory because it's clearly the fact that that's where their mind has taken them while they're feeling the emotion suggests that it's important.
That is so interesting. Thank you. There's another question related to treatment. What have you heard about EMDR?
Yes.
That eye therapy, yeah.
Yeah, so that's eye movement desensitization and reprocessing. So that's basically the same as the memory rescripting that I talked about, but the one difference is that there's some kind of what they call bilateral movement. So it's often just fingers. I'm going to stop doing that because I've just realized that's going to be a massive trigger for people. Sorry. So you probably wouldn't want to do that if you did have visual triggers, but it can also be like a pulsing, like you might have something that sort of gently squeezes your hand on each side. And theoretically, that's supposed to help with the processing of the memory, but we don't really understand what it is about that works. And the goal of that is the same as the memory rescripting that I talked about. It's the same thing, it's updating those memories.
Thank you. I'm going to squeeze one in here. Someone is asking, they're trying to see you at Oxford, but they've been told they have to see an audiologist and an ENT specialist first. Okay, so
I'm so sorry, whoever that is, I'm so sorry. That keeps happening. And then the audiologist and the ENT therapist keep coming back to us and saying, we don't know what to do. Like this, there's nothing, no treatment or change-based strategies. Some audiologists have some sort of noise things that they can do, but a lot of the time audiologists are doing CBT, the same sort of therapy that we're doing. So people often then just come back to us from them anyway. So I'm really, really sorry. There's no good evidence that is needed. There's no research suggesting there's really meaningful differences in hearing for people with misophonia. So I'm sorry. But yeah.
And I am with that, I'm going to thank everyone and thank Dr. Gregory because I'm moderating another panel. And thank you all very much. We have
Thank
a
you so
lot of
much.
unanswered questions. Thank you.
Thanks for having me.
Thanks, Dr. Ray. Thanks, Mike.